So now we're going to move on with the short talks. So the first one will be Dr. Rahul Gaurav, who is a researcher at the Center for Neuroimaging Research in the Paris Brain Institute at the Sorbonne University in France. And today is going to present on abnormal iron concentration in Parkinson's disease patients in the posteroventral nigral region and not in any other basal ganglion region over time.
Hello, everybody. Am I audible?
Yes.
And you see my screen, Claire?
Yes, it's good.
All right. Very good to see you all. I'm Rahul Gaurav. I'm at Paris Brain Institute of Sorbonne University. My department is movement therapeutics and research, and I'm also associated with the Center for Neuroimaging Research. So today I'm going to speak about abnormal iron concentration in clinical and prodromal stage of Parkinsonism, particularly prodromal like isolated REM sleep behavior disorder. So giving you a bit of a background about our team, like what we do. So as we know that many neuroprotection studies, they fail in Parkinsonism due to several reasons, like being noisy. Many other factors are not taken into account. Like, for example, in Parkinsonism, there is a big important factor of tremor. But understanding the finger taps using those tremors, but there are other things also there which can influence the finger tap. Let's say the person has arthritis, for example. So all these clinical trials eventually are useful, but it does not answer the full question. So in order to address this, our team is particularly focused on this question of what is called biomarkers. So, for example, biomarkers could be like high levels of lead in the bloodstream that indicate a need to test for nervous system, for example, in cognitive disorders, especially in children, let's say. High cholesterol levels, the most common ones, are a common biomarker for heart disease risk. So nonetheless, these can measure in various ways, from blood tests to skin biopsies to neuroimaging, which is our interest. So this is the focus of our team, which I wanted to mention a bit, like neuroimaging-based biomarkers for Parkinsonism. So giving you an insight about the question of the disease, like why we are focusing on Parkinsonism particularly. So according to several reports, there will be an increase in aging population in Parkinson's that could lead to Parkinson's disease in the future, which you can clearly see in the graph how United Nations is projecting it. So that makes us think that there is a need to, like sort of an urgent need to develop a reliable, strong biomarkers, particularly MRI biomarkers that can help in disease diagnosis, monitoring the progression of the disease, and analyzing the effects of the disease modifying treatments. So now let's give a bit of insight about what is Parkinsonism. We all know it's a multifaceted neurodegenerative disorder, and it manifests as a motor disorder and gets worsened over time. So it's quite well known that there is substantia nigra degeneration and dopaminergic loss takes place, which contains the neuromelanin pigmentation, and there is an increase on iron content. So after this is Parkinsonism, and my particular focus is idiopathic Parkinson's disease in Parkinsonism, but there is a question of prodromal that can help us like a window to understand the brain of Parkinson's disease. So let's say what are prodromal Parkinsonism. So this is the most common one which we study in our team, associated with Professor Alnouf's sleep disorder team at our hospital. So it's isolated REM sleep behavior disorder. It's considered a prodromal stage of Parkinsonism. It's a REM sleep parasomnia featuring unpleasant dreams, sort of violent behaviors, and sort of replicating, like acting out dreams in reality. So motor signs start to appear progressively for these subjects. And interestingly, there is also Parkinson's substantia nigra damage. So the question is whether there is iron content augmentation or not, like Parkinsonism, because these subjects, largely majority of them, with a window of 10 to 15 years, convert into Parkinsonism. So that could help us understand what goes on in the brains of these patients of IRPT. So let's see a bit of what is neuromelanin in the substantia nigra, which I just mentioned. It's a dark pigmentation concentrated in the dopaminergic neurons of the substantia nigra, and also, interestingly, in the noradrenergic neurons of the locus coeruleus, subcoeruleus, which is even harder to quantify considering the size. So it also accumulates during aging, which you can see in this plot, which I'm showing here, like how the neuromelanin goes up at around certain age from the childhood, around 60 or something, and then it starts to decline, which is debated what time it starts to decline and how it happens in aging population with respect to Parkinson's disease, which is the question here, which we are trying to understand. And you can also see here how Parkinson's disease patients have this lack of substantia nigra neuromelanin here with respect to a healthy volunteer on my left. So many of us already enlightened us about iron in substantia nigra today. So just a brief insight on that iron content can also be a potential marker for Parkinson's diagnosis, because there is an iron content augmentation in Parkinson's disease patient with respect to healthy volunteer that had been shown several times in various studies. Quantitative susceptibility mapping and R2 star allows us to quantify these changes. However, what is tricky, what is difficult to know is where is the change taking place? Is it in the entire substantia nigra, or is it in the territory, or where is it happening? Where is the iron augmenting? That is the difficult part. And how is the association with the iron augmentation and the decrease in neuromelanin, which is quite well known? How is it taking place? So that brings us to the question of very strong longitudinal studies, like 2 visits, 3 visits, to understand what goes on in the brain of these Parkinson's patients with respect to prodromal stage, like people who will convert into Parkinsonism, with respect to the healthy volunteer. So let's see what we did in our studies here, a bit of insight, a quick one on the material and methods, like what and how many subjects we were having here. So a quick overview on our subjects. So we here had 3 visits. So we were trying to have 47 healthy volunteers who came back, 31 of them, and 13 in the 3rd visit. So the gap, or the visit interval gap, is around 2 years between the 2 time points. And you have similarly for isolated REM sleep behavior disorder, the prodromal stage, and we separated the Parkinson's disease who manifested REM sleep behavior disorder, these ones, and the ones who do not manifest REM sleep behavior disorder, to understand the RN changes in these 4 subjects, to connect it with the role of the prodromal stage, where RBD lies. So what we did here, we used automated method to automatically segment the substantia nigra territory-wise in the QSM and R2 star maps. And then we had our previous studies on neuromelanin, where we had automatic AI-based segmentation models to quantify substantia nigra. And then we had another one for using template to quantify 3 territories inside the substantia nigra: limbic, associative, and sensory motor. So in these ways, we could have RN sensitive marker to quantify RN territory-wise using this method, and similarly obtaining the neuromelanin values in order to understand the interaction. So let's see a bit of insight on the result, what we had here. So here is a quick overview on how the segmentation took place. So what we did here, we tried to obtain a mean template using the AND software, and we asked our experts to segment manually the posterior anterior substantia nigra. And first we tried to develop dorsal side, which you can see on the top, the dorsal slice of the QSM, and then we tried to segment the ventral side, and we bifurcated like anterior, posterior, and then we denormalize using ANDs in all the subjects automatically. So first step was manual for QSM and R2 star, and then it was automatic for all the subjects. So second part was getting neuromelanin inside that, because it's a good important question for us, the interaction part as well. So for interaction, we already had our method in place that is automatically quantifying substantia nigra, which we published recently. You can see in this example here on my left is the Parkinson's disease where you could see in red is the automatic AI-based segmentation, and the yellow is the one done by manual segmenters, the experts. And you can see they're quite similar with the similarity index of around 85% or so. And you also can clearly see the drop in Parkinson's here with respect to the healthy volunteer. So this was the model for whole substantia nigra volume, particularly giving you a brief insight how it looks. When you throw the image in the AI model, it quantifies your substantia nigra automatically using the AI-based segmentation. So this is largely important for our whole substantia nigra segmentation in neuromelanin imaging. So second part was what we did a few years ago. It was a study by Emma Biontity, a postdoc in our team. So here we use the sensory motor, limbic, and associative territory, where we found that the changes are in posterolateral. So taking hypothesis from the past postmortem studies as well to understand the changes in the posteroventral region. So this was how we got the nigral territories as well by this topography thing. And so what we did, we had our RNA imaging results like segmentations, and we had our neuromelanin segmentation. And then we use our statistical model to understand these 3 visits, how the RN is changing. So what we found, interestingly, is none of the regions were changing except the posteroventral region here, which you can see on my left on A, is the box plot of the baseline, what we obtain on the posteroventral nigral RN. This is one with the QSM maps, and the results were similar for R2 star as well. So let's see what we obtained here. The healthy volunteer stayed somewhere here, and the Parkinson's disease without RBD, without the REM sleep behavior disorder, had the highest RN accumulation, significantly changing and going up. And interestingly, on my B, on my right, is the longitudinal change here, which is slightly noisy because not all the subjects were having the similar pattern, but you could see that there was strong group effect, strong visit effect, and all the groups were augmenting simultaneously over the time, over the 3 visits. And interestingly, what we found here, that as the RN augmented over the years, they were also correlating with the nigral neuromelanin changes, which we saw using the territory-wise method. So this is like overall signal-to-noise ratio for the neuromelanin change using the territory-wise method. So every time you see that the neuromelanin goes down and RN starts to go up. So this was correlating as well. And then in the next part, what we did here, we were trying to understand, particularly for the prodromal side, how are the changes taking place. So we are trying to track the evolution with respect to the age of the non-Parkinson's disease subjects like IRBD and healthy volunteers. So our 7 IRBD, very interestingly, converted into Parkinsonism over the course of the study, like around 4 years or so. It's quite a short number, but taking help from this, we were also, as a supplementary side of our result, we were trying to understand how we can model the progression. So here, what we saw that iron increase at the age of onset at 60.6 years would be approximately 10.7% compared to the mean healthy volunteer levels. So among the IRBD converters, like the 7 ones which I mentioned, this model predicted that there is a greater increase in the group at the age of onset around 66.5 years, reaching 27.6%. So that was an important insight. To summarize the results, as mentioned, the QSM showed posteroventral substantia nigra increase, not in any other region, just in that region. And particularly the Parkinson's disease without RBD showed around 18% of RN augmentation with respect to healthy volunteers. Others were not significant. And longitudinally, we saw group and time effect, not interaction for QSM, but interaction for R2 star, perhaps because of lesser subjects in the 3rd visit. And the RN progression model, as I mentioned, increase at age of onset around 60.6 year would be approximately around 10.7% compared to the mean healthy volunteer levels. So final words. PD patients without RBD had increased iron only in the posteroventral nigral region obtained using the template, and it related to the disease duration. Like as the iron augmented in this region, the level of illness also increased, like their disease duration also was correlated positively. And also what I showed you, the neuromelanin signal intensity was correlated negatively. It went down and the iron went up. So overall, it's multimodal MRI biomarkers like neuromelanin sensitive imaging and the quantitative MRIs like QSM and R2 star can have a strong potential in this idiopathic, and particularly for the subjects who are at risk of developing Parkinsonism, like isolated Ramsey behavior disorder. So with this, thank you very much for your time, and shout out to my team. Thank you very much.
Thank you very much for your presentation. It was very interesting. So we are already a bit behind the schedule, but maybe we can take 1 or 2 questions maximum. Mark, do we have any?
Yeah, okay. So the first question that came in was from Aurelie Bussy. She asks, could you please discuss the potential impact of MRI resolution on the extraction of quantitative measurements in such a small structure? And how does the change of microstructure over time impact this segmentation accuracy?
Yes, very good question. And it's always sort of a limitation, which we should always say. There's all these sort of studies are not validated with post-mortem samples, for example, what we were talking about today. So these are always slightly noisy when you are segmenting those subjects, which are patients you are scanning. Even in neuromelanin, the quality is not that similar. I mentioned about locus is quite similar. So surely the precision is not the same. I think the way the future is having all models validated by the post-mortem samples to have the precision. So what we are trying to do, we're using the template to sort of denormalize in the subject space to get the measures, but staying to the in vivo patient scans to reconstruct every time. In my studies, we do not have any comparison with post-mortem, and that's a pity. So I agree, it's a very strong limitation all the time for these sort of studies with tiny regions.
Right, thank you very much. I will save the rest for the discussion.
Great, thank you again.